All right, let's dive into the CAP protocol for uveal melanoma. Now, if you're a pathology trainee, you know these protocols can be, well, a bit dense. So today, our goal is super simple. Turn that document into a clear, practical guide you can actually use when you're at the bench. So picture this. The specimen container lands on your bench. Inside is an N-nucleated eye. It can feel a little intimidating, right? But every single thing you do from this moment on directly impacts that patient's prognosis and treatment. So let's walk through it together. Every step from this first look to the final report. Here's our game plan. First, we'll talk about why we're so obsessed with sticking to the protocol. Then, we'll follow the specimen's whole journey from the grossing bench to the glass slide. After that, we'll get into what to look for under the scope, how to turn that into size and staging, and finally, we'll cover the crucial ancillary studies that complete the picture. So, why all the fuss about a standardized protocol? Well, uveal melanoma might be rare, but it can be incredibly aggressive. The CAP protocol basically creates a universal language. It means a pathologist in one city and a pathologist 1,000 miles away are collecting the exact same critical data points. This gives the oncology team the precise, consistent information they need to best treat their patient. It's all about clarity. And the protocol structure is built for that clarity. You have this mandatory synoptic format, just data element response. It totally removes any ambiguity. The core elements, you have to report those every single time. Conditional elements are for when you see something specific. And then there are optional elements that depend on your lab's own practices. It's a whole system designed for precision and nothing less. Okay, let's head over to the grossing bench. Seriously, the measurements you take and the sections you submit right here, they're the foundation for the entire diagnosis. Getting this stage right is absolutely non-negotiable. First off, let's make sure we're on the same page with a key term, enucleation. It just means the surgical removal of the whole eyeball. This is, by far, the most common specimen you're going to see for uveal melanoma, so understanding what was done in the OR is step one before you even think about making a cut. So here is your 4-step workflow. First, fixation. Be patient. Give that globe a good 24 to 48 hours. And whatever you do, do not inject fixative or cut windows into it. You'll wreck the anatomy. Next up, orientation. Then, transillumination. This is where you shine a bright light through the eye to see the tumor's shadow and mark its base. And finally, the hero cut, the pupil optic nerve, or PO section, which you want to slice perfectly through the center of the tumor. Now, if you remember just one thing about orienting the globe, let it be this. Find the optic nerve. Okay, got it. Now look for where the inferior oblique muscle attaches. It will always be on the temporal or lateral side. This one little landmark is your compass. It's your most reliable guide for figuring out left versus right and nasal versus temporal. All right, we're moving from the gross bench to the microscope. The slides are ready. It is time to look at the cells themselves. This is where we figure out the tumor's personality. Is it aggressive? Is it slow-growing? This is where we start to really understand the patient's prognosis. This right here is the modified calendar classification, and it is a huge prognostic factor. It really just boils down to cell shape. Tumors made of mostly long, skinny spindle cells, they have the best prognosis. Tumors made of big, round, angry-looking epithelioid cells, they have the worst. Most tumors are a mix of the two, so the key takeaway is simple. The more epithelioid cells you see, the higher the patient's risk. And hey, don't just take my word for it. The protocol itself puts it in black and white. Spindle cell melanomas have the most favorable prognosis, and epithelioid cell melanomas the least. This isn't just some academic exercise. Your call on cell type has a direct, profound impact on predicting that patient's survival. So once you've typed the tumor, your work's not done. You have to put on your detective hat and check all the places this tumor could have spread. Is it creeping into the sclera? Is it in the optic nerve? Has it broken out of the eye completely? Every single yes on this checklist can potentially upstage the tumor and make the prognosis worse, so you have to be meticulous and look everywhere. So we've looked at the what, the cell type, and the where, how far it spread. Now let's talk about how big. This part is all about the numbers. It's about taking precise measurements that you'll then use to determine the pathologic T category, or the PT stage. These are the two measurements that matter more than any others. First, the greatest basal diameter, or GVD. That's how wide the tumor is where it meets the back of the eye. You can think of it like the tumor's footprint. Then, there's the greatest thickness. That's its height, measured straight up from the base to its peak. You'll measure these on the gross specimen, and then you'll confirm them under the scope. Now here's a key detail you can't forget. The rules for staging actually change depending on where the tumor started. If it's a rare iris melanoma, staging involves things like how many clock hours it covers. But for the much more common ciliary body and choroid melanomas, it's all about those two measurements we just talked about, basal diameter and thickness. You plug those into a chart and that gives you a PT category from 1 to 4. And this is why those size categories are so critical. There is a direct, undeniable link between the PT category and the patient's prognosis. A PT1 tumor, small, best outlook. As you climb up to PT2, PT3, and PT4, the prognosis gets significantly worse. Your measurements with that little ruler directly map onto this survival curve. We've covered the gross exam, the histology, and the staging, but modern pathology goes deeper. This last section is all about the ancillary studies, the tests that give us those final, crucial pieces of the prognostic puzzle. Okay, here are the big four you need to know. Gene expression profiling, or GEP, is huge. It separates tumors into low-risk, class 1, and high-risk, class 2, which is a game changer for predicting metastasis. BAP1 is a simple stain. If the tumor cells lose their nuclear staining for it, that's a really bad sign. PRAM is another key marker. And of course, the good old mitotic rate, just counting how fast the cells are dividing, is still a cornerstone of prognosis. And this is where it all comes together. You take the gross findings, this cell type, the invasion, the ancillary results, and you put them all together to come up with that final PT&M stage. This isn't just a summary for the chart, it is the single most important piece of information you will give the clinical team. It dictates literally everything that happens next for that patient. And that brings us to the end. You see, your report is no longer just a list of data points. It's a narrative. It's the story of this specific tumor, its personality, its size, its aggression, and maybe even its weaknesses. You're not just a pathologist signing a case out. You're the storyteller whose detailed, accurate, and standardized report is going to guide the next chapter in your patient's care. Never, ever forget the power of that story.